And now I'm happy to call Simon Rushbrook, a gastroenterologist and hepatologist at the Norfolk and Norwich University Hospital NHS, and he will talk to us about the updated guidelines for the British Society of Gastroenterologists about the management of patients with cholangio. Thank you, Simon.
Yes, I'd like to thank everyone for the invitation to come and present the guidelines on behalf of the writing committee today. So obviously this was a long time in the making. It was last published, this guideline, in 2012. And as you can see from the right of this slide, there really was an exhaustive panel of experts that came together from multiple specialities to write this guideline. And what you ultimately hope is that the specialists on this panel represent the specialists on MDTs when patients with cholangiocarcinoma are discussed. Now, the idea of a guideline is to really generate a set of high-quality care statements. There's nearly 50 of these in this guideline, and what we hope is that by writing these things down, it should help formulate and guide clinicians on how best to manage patients to try and reduce some of that variation in care that Helen so eloquently demonstrated. Now, in terms of the guidelines, we have deliberately not really focused on gallbladder cancer or ampullary lesions. We felt those probably needed their own guidelines in their own right. And as you've heard, they principally focus on the three subtypes of cholangiocarcinoma. And we spent a lot of time in the guideline also writing around endoscopic care of patients who present with malignant biliary tract obstruction, whether that would be at the top of the bile duct, so-called PMTO, or at the bottom of the bile duct, DMTO. So it's always hard when you're presenting a guideline to know how best to do it, because it would be a bit dull if I just sat and read 50 quality care statements to you. So I thought what I'd do is I'd take 3 patients that I've recently seen in the clinic, one coming through a 2-week wait pathway, one presenting as an emergency admission with jaundice, and another one referred on a jaundice pathway. And what we felt, first of all, that was important to say is that all patients presenting with jaundice, there should be at each centre a seamless pathway for that patient to get into a local or a regional MDT of expertise. Now, like most patients with HBB, cancers and cholangiocarcinoma, often ultrasound is the first step, and that's what all these 3 patients underwent. Case 1 showed a large liver mass. Case 2 showed that the ducts in the liver were dilated, but they weren't dilated below the liver, suggesting there was a blockage at that hilar area, or the perihilar area, as Professor Khan has taught you about. And there was also case 3 that showed that the entire ductal system was obstructed with jaundice, suggesting that the blockage was at the bottom. And obviously these are what case 1, 2, and 3 are meant to represent, the intrahepatic, the perihilar, and the distal. Now, the first step for all patients with cholangiocarcinoma after ultrasound that we recommend is that they have a contrast multiphasic CT, the idea that you're characterizing the lesion, you're determining its relationship to important vascular structures, you're looking for lymph node involvement, and looking for distant metastasis. We also recommend for intrahepatic and for perihilar that the patient also has an additional MRCP and dynamic MRI to help characterize things and potential involvement of the bile ducts. But for distal cholangiocarcinoma, we felt that MRI at the start of the pathway didn't add anything else in addition to multiphasic CT. Now, as Professor Khan's already said, there are many risk factors for cholangiocarcinoma, and what we've tried to emphasize in the guideline is the importance of looking for those at your initial assessment, looking for risk factors as well as taking a very detailed history, looking at a patient's comorbidities, looking at their performance status, and where your tests show you to date. And once you have that information, of course, you're going to discuss that patient at an expert MDT, being very careful to document in the MDT's opinion, first of all, what type of cholangio you think it is to help with future epidemiological work, but more importantly, documenting the investigations, the risk factors, the staging, the comorbidities, and the performance status to help formulate a management plan. We recommend that PET is in part of your staging because it helps uncover unexpected distant mets and lymph node staging. And obviously, as in case 1, where there's this obvious mass, if you're going to do a biopsy, that would normally be undertaken by ultrasound or CT guidance. And this is just a little review of case 1 thus far here. Unfortunately for this patient, there's an intrahepatic mass shown on PET. And the MRI added something. It showed 2 small metastases that weren't expected on the CT, showing this added value of further dynamic imaging. We stress quite a lot in the guidelines about accurate staging to MDTs using the latest iteration of guidance for TMN staging. In terms of the first important decision at the MDT, which is surgical, we write some sensible, high-quality statements. Obviously, the decision to proceed to surgery should come about after a review of the cross-sectional imaging. That obviously there needs to be some very careful thought of how much liver is left after this resection by the surgeon to make sure the patient doesn't develop post-operative liver failure, and very careful decision-making around biliary drainage to optimize the recovery of the liver that's left after the surgery. We've talked about that staging laparoscopy should be used very sparingly in selected cases, and reminded the reader that really it is R0 resection you are aiming for in your surgery. And once again, there is a statement around, and Helen's alluded to this, that these operations need to be done in high-volume centres where you have multimodal expertise to help patient care. Now, for patient 1, who sadly couldn't be operated on, who went on to have a biopsy, Dr. Tim Kendall has obviously written the pathological section of this guidance and wanted to remind you, when he talked about the preparation of that block of tissue yesterday, we need to use that tissue sparingly because we don't want to waste the tissue and avoid a potential chance of having enough material to do the molecular testing that obviously is recommended in the guidance to make sure that for patients that aren't going down an operative route, they have access potentially in the future to targeted molecular therapies. In addition to this, we have made a lot of emphasis in the guidelines, and this is what is lovely to have, is patients representing on your clinical guidelines, that all patients should have expert hepatobiliary nurses to support them along their journey of care. We've also recommended, as Alan showed us yesterday in the photographs of his sequential physical appearance where he lost a lot of weight during his cancer journey, that you should also have access to dietitian support to maintain your nutritional status, and that all patients deserve the right for high quality information. We've heard from endless videos of brave patients that have come forward with their story, how overwhelming it is at the start of your journey to absorb all the information you're being given. And for all patients, they should have the right to see and seek a second specialist opinion. Sometimes it's very hard to accept that a particular treatment modality is not available to you, and sometimes you need to just hear that from someone else and make sure that was the right decision for you and your family to feel comfortable. We've also recommended that in parallel to those initial referrals, that patients are referred on a palliative care referral. That is to really help and ensure that symptoms are looked at and to ensure that other things that sometimes as clinicians we're not so good at, spotting mild depression coming about and anxiety that's related to a cancer diagnosis, are treated well. And we know from evidence that early palliative care referral improves those symptoms. We've also recommended there needs to be a lot more work about symptom management in cholangiocarcinoma. We often look at very hard endpoints, don't we, of survival and progression-free survival. How can we look at these endpoints and look at those in clinical trials in more palliative settings? Now, obviously, in terms of oncology, I'm not going to say anything that hasn't been alluded to in the guideline that you haven't heard already. Now, this is the nice example of BSG guidance. You can make these guidelines dynamic. You can change them as things change and the field moves forward. And at the time of writing this, really, we said the initial chemotherapy based on ABCO2 should be cisgem, but we are now updating that to say from the TOPAZ trial that obviously immunotherapy in combination with cisgem should be considered first line, and those changes are now being updated by Professor Khan and the team. We've recommended, obviously, molecular profiling is very important and treating people with second line and considerations for those. And obviously suggested that molecular profiling should be done at diagnosis. It's not something that should wait to be done and delay a patient's journey. So that needs documentation at the MDT that it's been thought about and it's being looked to see if it can be done. And finally, we've talked about potential, if you have surgery, the role of giving chemotherapy afterwards based on the BILCAP data and capecitabine, but don't recommend that you give chemotherapy up front before an operation unless it's in the context of liver transplantation, which we'll talk about later this morning. In terms of radiotherapy, we've highlighted the importance of having oncologists that deal with multimodality therapy. So you look at and consider all modes of potential oncological treatment, highlighting the role of SBRT, potentially in the treatment of localized disease and oligometastatic disease. So to move to case 2, which was obviously perihilar cholangiocarcinoma. The first thing we wanted to remind about is this is where people tend to present with strictures and narrowings in the biliary tube, and we wanted to remind the reader that not all narrowings are cancerous. Sometimes there are other causes of narrowing in the hilum and narrowing in the distal bile duct. And one of the important parts, apart from looking at risk factors in your initial consultation, is the consideration, am I dealing with a potential benign etiology of this presentation? We've talked about the radiological assessment. We recommend dynamic MRI, MRCP, and multiphasic body CT and PET scanning, as shown in the examples here for this patient, showing some stitching at the hilum of the bile duct. Now, the most important message we wanted to make sure is that people are not touching patients with perihilar disease with endoscopes until the case has been carefully thought through at an MDT, and hence that was one of our recommendations. No one should be having endoscopic therapy until an expert group have decided that's the right thing to do and what intervention you want to do. We've made some generalized points that you should never be doing endoscopy and you've done all your imaging, because if you do something, it could induce inflammation and changes that could affect your subsequent staging. And at the present time, we didn't feel as a group that we could replace standard pathological reporting, such as scrapings from the bile ducts or bites from the bile ducts or biopsies, over next generation sequencing. But we have strongly urged people to do consortium-based studies where we look at bile, we look at the biliary brushings to see if we can improve our ability to diagnose these very difficult cancers. And finally, we heard yesterday about patients going through cycles of investigations, negative results, potentially delaying and avoiding surgery. In this guideline, we wanted to give clinicians the permission, in discussion with the patient and with very careful counselling, that sometimes surgery is the right decision to get a pathological diagnosis where you're failing to do it by other means, and also potentially offer that patient an operative procedure and a cure potentially. Now, in terms of perihilar, there's obviously a lot of debate about how you go about stenting bile ducts. Do you stent them on both sides, and how you do it? And we've tried to keep this open in the absence, in our view, of clear evidence. But we have suggested for patients moving forward with surgery, perhaps a unilateral approach, stenting the lobe of liver that you're going to leave behind to improve its function, and then only doing subsequent stenting, depending on the level of bilirubin, would be an appropriate choice, but didn't feel that we could dictate what way or how you stented. Do you do it from the bottom with ERCP, or do you do it through the side with PTC? For those patients that sadly have unresectable disease, we've once again tried to be pragmatic. We've obviously suggested that these cases need very careful decision-making, and what approach you take really depends on the expertise in your centre and whether you're going to do unilateral or 2 stents or more. At the time, though, of writing this guideline, we didn't feel that we could recommend doing additional endoscopic treatments to these patients with strictures in the bile ducts, such as photodynamic therapy or delivering radiofrequency ablation, and that's really in line with NICE at the present time until they change their opinion. And this is once again an example of a case of mine where we're going up into the bile duct after MD discussion, we're taking some samples and placing some stents in the biliary system. So let's move to case 3, this one where there's a distal blockage at the bile duct. And once again in the guidance, we remind you to think about other diagnoses. Consider these other causes of stricturing apart from cancer. And make sure at your initial clinic review, you are looking for those things and considering them as well as thinking about cancer. And obviously, once again, looking at comorbidities, looking at the performance status and risk factors. Now, once you have your multimodal CT and you've got a distal stricture here with some inflammation, from some contrast enhancement suggesting a possible pathological stricture of the bile duct, the guidance gives you some choices. We tried to keep it open. We know that some centres may take a view that that patient who is likely to have a malignant stricture at the bottom of the bile duct, may go straight for surgery. And we know that some centres around the country do that, avoiding any interventional procedures, potentially preventing pancreatitis and complications of endoscopic therapy, and going straight for surgery. The guidelines can advocate that approach. If you're jaundiced, we said, well, if you can, it's quite nice to be able to sample the bile duct and do a biopsy with endoscopic ultrasound. And if you're palliating jaundice, do a stent and brushings at the same time. That's often a good choice for patients. But of course, not every centre can offer that. So if you can't, an ERCP, where you go into the bile ducts and take some scrapings, is also acceptable. But what we have said that if you are going to do stenting, it's important to put the right stent in. And that really means putting a metal stent in to start with and not a plastic stent, because metal stents are much more durable than plastic stents. And that's really what these guidelines say here. We've also talked about new ways of draining bile ducts in the guidelines, and obviously, I mean, in this case, we were fortunate to be able to get into the bile duct and place a stent across there because this patient declined surgery after very careful discussion. But actually, sometimes that's not possible, so there are new ways of doing it by puncturing the bile duct and putting a stent into it, called endoscopic ultrasound-guided biliary drainage. And we've advocated that that could be considered more safer, potentially, than doing the old-fashioned thing, which is doing a PTC. But once you're saying it depends on your centre and what's available, and we've reminded of the people in the importance when introducing new endoscopic treatments for cholangiocarcinoma, it's really important to keep local audit data and governance data to show what you're doing is safer than what you used to do. Finally, which I think is a really important part of care, is what do you do and how do you follow up once stents have been put in? And here we remind people about the importance of having good stent care, regular blood test monitoring, acting quickly if there's signs of stent dysfunction, the need to do cross-sectional imaging to re-look at that case and understand what's going on with that stent if it's not working, and also remind people about the importance of having rescue antibiotics at home if you develop cholangitis, which always seems to happen at Saturday night at 2 o'clock in the morning when the last thing you want to do is go to A&E. We talk a lot in the guidance about the role of liver transplantation. I'm not going to talk about that because Professor Thorburn is going to very nicely go over that, but it really alludes to what hopefully you'll hear from Professor Thorburn in a few minutes on. And finally, at the end of the guideline, we present a series of statements of research about things that we think could be looked at very carefully within the UKRI and CCR UK and AMF charities that fund research for cholangiocarcinoma. So I thank you for your attention. I hope that was a whistle-stop tour, but it gives you a flavour for those statements that we've done. And as I say, we hope as a group that those will lay the way to ensure better care and access to care for patients. So I thank you for your attention.